Good morning and good afternoon to call participants in Europe. Welcome to the Chardan Key Opinion Leader Call, Emerging Therapies for Phenylketonuria, or PKU. A special thanks to our featured KOLs, Dr. Barbara Burton and Dr. Hope Northrup. My name is Keay Nakae. I'm a Senior Biotech Analyst at Chardan, where our focus is on identifying companies and themes that can generate exceptionally high long-term investment returns by creating shared value for society. During this call, we will not be discussing Chardan research. Any discussions about our research should be coordinated between participants and their respective salesperson at Chardan. A recording of this call will be made available to clients. Before we get started, our compliance team has asked me to read this statement. By participating in this call, our speakers attest that they have made Chardan aware of any potential conflicts, and they will not discuss any material, non-public, or confidential information that they are aware of that may breach their legal, regulatory, or fiduciary responsibilities to any parties. As for the goals of this call, what our audience participants are most interested in hearing discussed are, first, to better understand the patient journey for those with this disease, the effectiveness of current disease management strategies utilizing available therapies, and what are the prospects for emerging new therapies currently in clinical development, such as PTC's 923 or Synlogic's SynB 934, or gene therapy and gene editing candidates targeting PKU being developed by Homology and BioMarin. As for the format, this call will be about an hour long, and audience participants will be given the opportunity to ask questions after about 45 minutes or so. To do so, please type them into the chat box. So let's get started. I would like to first welcome our KOLs and ask them to provide a couple minutes about their background and their experiences with PKU patients in both their current clinical practice and in clinical trials. Dr. Northrup, why don't you start, followed by Dr. Burton.
Thanks so much. I'm Hope Northrup, and I'm a medical geneticist in Houston, Texas. I've been taking care of patients with PKU for a little over 35 years, and I started taking care of these patients when I was a trainee. So over time, I've become extremely invested in trying to increase their quality of life through better therapeutic options. And as part of that, I have been willing to try to help pharmaceutical companies bring new products to market, test new products, and see how they're going to be as far as helping our patients. The only way patients with rare diseases are ever going to have therapies is if we partner with the pharmaceutical industry, because there simply isn't enough patients out there for the pharmaceutical companies to want to bring a drug to market for such a rare disease on their own, and they need our expertise. So I'm really excited to be here today to talk with you a little bit about PKU. I also feel pretty strongly that the therapies that we've had for many years for PKU really have been highly inadequate. We've asked patients to adhere to almost impossible dietary therapy for their entire life. And what we've learned through many studies that have been done is this is virtually impossible for the patients to do. And so eventually the patients give up, they stop following our instruction, and this leads to problems. We also know that long-term, our restrictive dietary therapy has negative outcomes for patients. And I'm going to talk about those in a few moments. Thank you.
Great. Dr. Burton?
Absolutely. And let me apologize first. There's construction noise outside my window. I'm hoping this headset helps a little bit in muting that out, but I apologize if that's interfering with the sound for you. I'm a medical geneticist like Hope Northrup at Northwestern University in Chicago, where I'm based at the Lurie Children's Hospital. I've been in the field of genetics for about 45 years now, but during the early years of my career, I was at institutions where other individuals were caring for the PKU patients. So I've been taking care of patients with PKU intensively for about the past 24 years since I've been in my current position, where one of my responsibilities has been as director of the PKU clinic. We have a large population of PKU patients, both children and adults, about 320 in total. And so I have had extensive involvement in their care, but also have participated in a number of clinical trials of new therapeutics. I was very much involved in the Kuvan and pegvaliase palynziq clinical trials, and currently also continue to do research in the area of PKU.
Well, great. So, I think our audience generally understands that PKU is an inherited rare metabolic disease caused by an inborn mutation of the PAH gene, resulting in an impaired breakdown of ingested phenylalanine or Phe, an amino acid found in all protein-containing foods. So Dr. Northrup, could you first describe the different types of PKU, starting with the classic PKU term we often hear about and how it differs from mild and moderate forms? And second, could you expand on some of the longer-term complications of this disease?
Sure. So classic PKU is defined as having a level of phenylalanine in your blood greater than 20 milligrams percent or 20 milligrams per deciliter, 20 milligrams per deciliter on an unrestricted diet. There are individuals who have gene differences that make them have elevated levels that don't get quite that high. So normal people have a level of 2 milligrams percent or less, and we call people benign hyperphe when they have levels between 2 and 6. We carefully follow these individuals because if they do go above a level of 6, we want to intervene, because the recommendation of the American College of Medical Genetics in a really good position paper indicated that in order to prevent any long-term cognitive damage, we need to keep levels in our patients between 2 and 6 milligrams percent. And then there are individuals who have levels between 6 and 20, and those are your milder hyperphenylalanemias. And those individuals also need interventions, but usually not quite as much intervention as an individual of greater than 20. Now, we do know that our therapies result in problems long-term for these patients. And there have been two really great studies, one in the US that looked at over 3,500 PKU patients compared to over 18,000 controls in the population, and another one in Germany that looked at 375 PKU patients with about 3,500 matched controls. And what we learned is that these individuals who had PKU had some long-term medical problems more commonly than individuals in the population. For example, obesity or overweight in the US study was more than twice as common in the PKU population and about 1.5 times as common in the German population. And then there were some other problems that we see, very common morbidities in the population, like diabetes, asthma, heart issues, skin issues. These were also seen elevated in the PKU patient 1.5 to 2 times more commonly, depending on the condition, than the general population. But most importantly, what we see in patients with PKU are neuropsychiatric problems. One large study that looked at age brackets of 10 years, 10 to 19 years, 20 to 29 years, and so forth, looked at things like depression and anxiety. And when they looked in these different age brackets, comparing people with PKU to the general population, in many of the age brackets, the patients with PKU had twice the level of anxiety or depression recorded in the general population. All of the age groups, it was higher in the PKU population, but in some it was twice as high. And we know that people with PKU, when they have elevated levels, they describe difficulty with moodiness, attention, anxiety, depression, executive function, and all this is very well documented. So we know that we want individuals who have PKU to have levels within the recommended range, and it's really tough with the dietary therapy that we use for very many years.
Well, great. So, let's dive in now a little more into how PKU disease is managed today. There are 2 approved drugs which can supplement a specialized diet, low in phenylalanine, as you said. So in that regard, within the context of the patient journey for this disease, maybe Dr. Burton to start with diet. And can you describe the goals of treating PKU with diet management, and how successful is diet control alone? And what are the challenges, again, within the context of this patient journey that Hope had just touched upon?
Sure. Well, as Hope mentioned, the goal of any therapy of PKU, whether it's pharmacologic or diet, is to keep the blood phenylalanine level below 6 milligrams per deciliter or 360 micromoles per liter in order to achieve optimal outcomes, in order to achieve optimal IQ and avoid many of the symptoms that she described. Dietary therapy is typically initiated as soon as the diagnosis is made after birth, assuming the level exceeds the threshold for treatment of 6 milligrams per deciliter. And then other pharmacologic therapies may be used. But our therapy is usually successful in maintaining good metabolic control in our preschool patients. So say from 0 to 6 years of age, unless we really have a dysfunctional household, we have a situation where the parents are almost completely in control. So most of our young children are well controlled. But once we see kids starting to get into the school age group, we start to see slippage in that metabolic control. They have many more opportunities for food sharing, and they have more autonomy and independence. And parents also become more complacent because they see their kids doing well and life gets busy. So we start to see some patients with higher than ideal Phe levels, even in that 6 to 12-year age group, but it gets progressively worse after that. And as we get into the teens, we have more and more patients in poor metabolic control. I think the data show us that about 50% of our adolescents have elevated blood Phe levels beyond where we would like to see them. And then when we get into adult life, it's probably closer to 70%. So we see progressive loss of metabolic control over time, not due to any intrinsic property of the disorder. We can control anybody if we put them in a hospital room and totally control their intake, but just due to life circumstances. And for adults, it's particularly difficult because some of the products that they need for dietary control are very expensive, and our PKU patients may be underinsured compared to the general population because they have lower paying jobs in some cases. And so it just is it's kind of a progressive problem over time.
And Dr. Burton, in terms of the acuteness of the symptoms, does that also play into perhaps a lack of rigor, especially in adults, for adhering to diet management?
Absolutely. I mean, it plays in at all ages, really, because this is not like a diabetic where if they don't, comply with therapy, they may land in the hospital. And although we do see some patients who can perceive a rise in their blood Phe level, especially if it's acute, and some parents who see it in their children, we also see a lot of patients where this has been just kind of a chronic, slowly evolving situation over time. And the patients don't necessarily perceive that they are having all of the executive functioning deficits that Hope mentioned. They may not really recognize that they have problems with anger management and forgetfulness and some of these other issues that their family members may see much more clearly, or their coworkers. Sometimes if we are able to get a patient who's been in poor control back in control, then suddenly they wake up and they see these things. So I think a lack of self-awareness is also one of the characteristics that we see very commonly in the PKU patients with elevated blood Phe levels, and it adds to the complexity in trying to treat the patient and help them regain good metabolic control.
Okay, so let's move on then to discussing Kuvan or sapropterin, which was the first FDA-approved medication for PKU. And Kuvan's a cofactor approach designed to get more function out of existing PAH enzyme. So Dr. Burton, can you tell us how you currently utilize this drug?
Sure, absolutely. In our clinic, we test essentially every patient that we see for responsiveness to Kuvan or sapropterin. Most of our patients, of course, come in through newborn screening. Occasionally we get one from another country or elsewhere, who hasn't been screened at an older age, but most of them are infants. Our practice is to stabilize them first on dietary therapy, and then somewhere around 6 months of age, unless we know they have two clearly BH4 non-responsive mutations, we will give them a trial of sapropterin to see if they're responsive. If they are, they stay on the therapy. If they're not, they come off. And we find about 35 to 40% of patients in our practice do respond to the medication. So it's a drug that's not useful for 60 to 65% of the PKU population. They have no benefit from it at all. And that's one of the disadvantages of it. But the patients with BH4 responsive PKU do benefit, although to varying degrees. We see a very small percentage of patients. It's about 7% in our practice. We have 23 patients in our clinic whose Phe levels are managed with Kuvan or sapropterin alone without the need for any dietary protein restriction. These tend to be patients who have a later rise in the blood Phe level. They're at the mildest end of the spectrum. Maybe they didn't require treatment at birth, but over time, as the protein content of the diet increases, the Phe levels rise. So for those patients, it's of course a wonderful treatment. It's a simple, easy, once a day oral therapy. So it's excellent for them. The remaining responsive patients, and that's about 28% of our practice, they still require dietary phenylalanine restriction. Some get more diet liberalization than others. They typically get some diet liberalization. They're able to tolerate somewhat more Phe than in the absence of treatment, but again, still requiring a specialized diet.
And in terms of those who are allowed to modify their diet while on the drug, how much modification could be termed a win? How does this really impact their daily lives?
Honestly, I would say that most of the patients see any modification as a win because the Phe-restricted diet is extremely restrictive. I mean, not everyone appreciates that it usually involves no meats, no fish, no dairy products, very little in the way of commercial grains, wheat, rice, anything like that. Even some vegetables and fruits have to be limited in quantity, certainly in the most severe patients. And then they supplement with low protein food products, but get much of their nutrition from the specialized medical formulas or foods that don't contain any phenylalanine. So it's a very restrictive diet. So I've found that patients who even can eat more of the food that they already were able to eat appreciate that. But oftentimes with Kuvan, we get more liberalization than that. I would say, it's not uncommon to see a tripling of the Phe tolerance from maybe 350 grams to, 1,000 grams. Once you get to that much, the patient can maybe switch over to counting grams of protein instead of milligrams of Phe. They may be able to eat more regular bread, pasta. They're still going to be on a vegetarian diet largely, and some may still often require the medical foods or formulas for adequate protein intake. But I think, it's that sort of diet liberalization is definitely appreciated by the patients. Would they like more? Of course they would. I think the motivating factor for almost every PKU patient as they get older would be to get rid of the diet altogether.
In your experience, how durable is this therapy? Again, given that it sounds like any benefit is viewed as positive, why would somebody try it? They're getting maybe that, even a minimal amount of benefit. Why would they choose to go off of it? Or do they stay on it?
I mean, there's a couple reasons, I think. Many of the patients stay on it, for many, many years, but we do see patients who just get tired of taking a medication or, whether they're taking the pills or the powder, they just see, well, maybe I'm not getting enough benefit to really make it worthwhile having to take a medication. So we do see that occasionally. I mean, the benefit is durable. There's nothing that changes about the benefit. What changes over time is the patient's adherence to the Phe-restricted diet. So whereas our young children on Kuvan may be well controlled over time, just like the patients on dietary therapy, they are veering away from the dietary restrictions, so that we have lots of adolescents and adults who are on Kuvan whose Phe levels are not ideally controlled. They're probably better than they would be in the absence of the medication, but they need the dietary protein restriction on top of it, and that is what we see lapse or lessen over time. So we do see some adolescents or adults who choose to switch from Kuvan to Palynziq, for example, where they know that most patients, if they're able to tolerate the early months of therapy, the side effects and so forth, and make it to the finish line, we can get most of those patients to a normal or a near normal Phe level on an unrestricted diet. So the motivation for them is getting rid of the diet.
Well, great. I think this is a great transition to Palynziq or pegylase. It's the more recently FDA-approved medicine for PKU, and PEG's a substitute enzyme that can digest Phe in the blood. So, Dr. Northrup, can you tell us how you currently utilize this drug in your practice?
Of course. I will start by saying that I was the PI for our site in the phase 3 trials. So our experience at my center extends beyond the 5 years of FDA approval that was May of 2018 in the United States, where Palynziq was approved for use in individuals 18 years of age and older who had levels greater than 600 micromole per liter or 10 milligrams on their current regimen, whatever that would be. And I think it's important to note that in the studies, many of the people came into the studies completely off diet. So I have patients who even have been lost to follow-up who've come back to me when they've heard about it, who've been off all therapies, who have started this drug. And as Barbara mentioned, this drug does, for some patients, give the ability with a daily injection to have a completely unrestricted diet and to have levels even in the levels same as the normal population, or 0.5 to 2 milligrams per deciliter. So this is a great option for some people, and I offer it to everyone in my practice who's 18 years of age or older who is struggling with whatever regimen that they're on at that time. Now, it does have drawbacks. So it is an injection, which is very different for patients than an oral medication like Kuvan. And you have to learn how to inject yourself. We also know that it can take a very long time to reach efficacy. The longest person in the clinical trials prior to reaching efficacy was 57 months. So a very long time for some people. And there are patients who take even 2 years. And it's a little hard to keep injecting yourself every day with no response for several years until you can reach efficacy. So that's one problem that we have with pegvaliase, now trade name of Palynziq. A second problem are the side effects. Because we are injecting a foreign protein that is pegylated, so it's wrapped in polyethylene glycol, and you are introducing 2 foreign proteins into that person's body, your body's going to respond by trying to fight it off, as your body is supposed to when you have a foreign protein introduced. So side effects are seen in almost every single patient who tries this drug. And sometimes the side effects lead to the point where the patient becomes so discouraged that they want to stop using the drug. And I've had some patients make that choice. We also know from the clinical trials that 10% of patients have a severe hypersensitivity reaction of anaphylaxis. We know that those patients, none of them had any adverse outcome. We do not know of any patient having anaphylaxis on Palynziq having a long-term residual adverse effect from that. But we do know 10% can have this anaphylaxis. And so for that reason, there's a very strict program in place for the providers and the patients to try to make sure everyone understands anaphylaxis, how to recognize it, and how to then treat it. And every single patient who is on this drug is required to know how to use an epinephrine pen and to have an epinephrine pen with them 24 hours a day, really for the rest of their life. Because we know this anaphylactic event usually occurs within an hour of injection, and it usually occurs during the first 6 to 8 months of using the drugs, but it can occur years later, and it can occur further out in time from an injection. We also know that there are some people who require more than one daily injection, depending on the dose they need. The drug is now approved for a dose of up to 60 milligrams a day, and it comes in pre-filled syringes, and there are 20 milligrams is the highest number in a pre-filled syringe. So the side effects, in addition to anaphylaxis, I want to mention the other side effects include joint pain, which can be severely limiting to activities of daily living, and the medical team needs to treat right away. Of course, injection site reactions. The area red has a hard reddened area, rashes, and we can see other hypersensitivity reactions beyond anaphylaxis. So patients really do take a lot on when they decide to use this drug. They know they're highly likely to have side effects. Some can be very frightening. They also know that it may take a while to start seeing efficacy. And during that time, they've got to keep their diet the same, whatever their diet has been. And they then also have to keep in touch with their medical team with regular check-ins, regular levels, and it can get very fatiguing. I've also seen a problem in some of my patients who've been on the drug long term with areas of their skin where they inject becoming hardened and scarred. So of course, we teach them to rotate injection sites with 4 different quadrants in the abdomen, the upper thighs, the back of the arms, and the upper buttock. However, even with that, over many years of injecting yourself, you can have areas where you get scarring. And I'm concerned about that long term with the medication, as are the patients. And also, patients just experience injection fatigue. I mean, a daily injection, subcutaneous injection, that's a lot for a patient to take on. Now, on the positive note, I have patients who eat 100 grams of natural protein a day who are on this drug, who have PKU and have normal phenylalanine levels. And I mean, I'm in Texas where those guys want to eat their steak. And so for many patients, it's been very freeing to be able to have a completely unrestricted diet, no medical food, no other therapies. So it's a balance. It's a drug that's been, I think, highly successful, but it also has its drawbacks and issues.
Well, great. So let's talk about some of the current therapies that are making progress in the clinic. And maybe a question for both of you, and I'll start with Dr. Burton. But what would an ideal therapy look like to you?
Oh, well, that's easy. An ideal therapy would be an oral once-a-day treatment that normalizes the blood Phe level in the absence of any dietary therapy.
And Dr. Northrup, I would imagine you concur with that.
Totally. If all they had to take was an oral therapy every day and they could eat like everyone else with no other interventions, that would be the golden ring.
Okay, but falling short of that, if we had an oral daily that really further reduced the restrictions on the diet, it sounds like that could be quite well received, assuming that the safety profile is also fairly benign. So let's talk about some of these newer drugs, and we'll start with PTC's 923, or synthetic sepiapterin, which is similar to Kuvan. It's a cofactor approach designed to get more function out of existing PAH enzyme, but with the promise of having greater bioavailability. 923 is currently being evaluated in the Affinity phase 3 trial, with results anticipated in the first half of this year. Briefly, the trial design utilizes a 2-part design. Part 1 first identifies patients who are responsive to the drug after 2 weeks with Phe lowering, and then they're advanced into part 2 of the study, where they are randomized to receive either the drug or placebo for 42 days. The primary endpoint is change from baseline in Phe levels among those patients with Phe lowering greater than 30%. So Dr. Burton, based on the clinical data presented to date, What is your outlook for this drug?
I think it's likely that they will be successful in the phase 3 trial and it will be approved. I see it basically as a better version, if you will, of Kuvan or sapropterin. As you said, it is the same approach in essence because sepiapterin is very rapidly converted in the body to BH4. And so this I see as a drug for the BH4 responsive population. I don't think it's going to make significantly inroads into the BH4 non-responsive population. They may pick up a small fraction of additional patients with the greater efficacy that they've been showing, and that sometimes if we test a patient with Kuvan and they have maybe a 10, 15, even 20% response, we may not treat that patient because it may not seem like it's worthwhile to take a drug every day for that, minimal type of response. And it's hard to distinguish it from noise, just the normal variability of Phe levels. So if they have greater Phe lowering effect, they may pick up a few of those marginal Kuvan responders that are not currently being treated. But I think it's going to be primarily for that population. They've tried to argue that they're going to make greater inroads into the classic PKU population, but I don't think it's going to be substantial, just perhaps the ones that I've already mentioned. But I do think both in their phase 2 trial, where they, in the same patients treated with Kuvan, and then with 2 doses of their drug, they showed greater Phe lowering. And in the recent data they released showing greater than 50% Phe reduction in the patients, mean Phe reduction in the patients in the current trial. To me, it looks like they are getting greater Phe reduction than we see with Kuvan. We're not going to have a head-to-head comparison in the phase 3 trial. This is placebo controlled. So I think they need a very robust Phe response to have physicians look at this and say, well, yes, that's greater than what we get on average with Kuvan. We certainly get Kuvan responders who have a 50 or 60% reduction in their Phe level. But that, I think, is not the mean reduction that we see. We see lots of them with a 30, 35%, 40% reduction. So I think if they get that kind of robust Phe reduction in the final data analysis, that will suggest that it is more efficacious. And I think, it will get pretty wide utilization, but again, in that subset of BH4 responsive patients.
So in your practice, if approved, how quickly would you switch over your Kuvan patients to this? And is there anything in the safety profile that would make you more cautious relative to Kuvan?
Well, of course, we haven't seen the safety data from the phase 3 yet, and that'll be important to look at. They had some headaches in the phase 2, so we'll have to see. They are using a large dose, 60 milligrams per kilo, as compared to the 20 milligrams per kilo we use with Kuvan. So I think, the safety profile will be important, but assuming it looks pretty clean, I would discuss this as an option with all of my patients on Kuvan who are not currently in ideal metabolic control or who have significant dietary Phe restrictions, because, if it is more efficacious, we should be able to achieve greater diet liberalization. That small population of patients who are well controlled now on Kuvan, they're really not going to be candidates for a switch. We have a generic version and most of them are on that. But I think the others who still require protein and Phe restriction would all be candidates. And it is the drug that I would choose to use to test any new patient coming along, assuming the payers allow that. I mean, one question I have in my mind is, would the payers possibly require that a patient fail Kuvan or the generic Kuvan, sapropterin, before allowing them to be treated with the PTC product? And I don't know how that's going to play out, but if it were solely up to me without that type of restriction, I would use it preferentially as a first line drug.
Great. Well, let's move on to Synlogic's SynV 1934. It's poised to advance into a phase 3 study. So Dr. Northrup, based on the clinical data presented to date, what do you like or dislike about this drug so far?
So SYN 1934, I think is pretty exciting because it's a completely new modality. So it's a probiotic, and this has a vast experience in probiotic use in the United States, and patients are going to know exactly what we're talking about when we talk about a therapy that's based on a probiotic, which has limited side effects and is widely accepted for use in the United States. So that's exciting. Also, the fact that it's a completely different way to approach it, and it can potentially help all the patients who have PKU. We do not know yet whether there are going to be patients who don't show as good a response or a great response to it, but we're going to be finding that information out in the near future. It's not going to be a replacement probably for everything we're currently doing in PKU, because it's also going to be more like an adjunctive therapy like Kuvan, where it's not going to completely move you down into the normal range. It's going to help with diet liberalization. Now, drawbacks would be that you're going to be taking it multiple times a day. And so that's an issue. And, we have to make sure that there's not a lot of GI upset, taste issues that are going to keep people away from it. So I think it's going to be an exciting one. And the other potential excitement I see about it is that it will potentially be like Kuvan, used in all age groups. It's not going to have a restriction like with pegvaliase, where it's so complicated as far as side effects and time to efficacy. It's going to be a completely different ballgame, more like the Kuvan situation, but more likely to be able to help more patients who have PKU.
So great. So given those characteristics of 1934, and assuming we continue to see good results in a phase 3, if approved, how would you initially use it in your practice?
Again, I would offer it to all the patients to make sure that they have that opportunity. Some who are already using pegvaliase are not going to be interested, but other patients who are still struggling, or even patients who are currently on Kuvan, maybe the two could even be used together to get a synergistic effect and be able to use even more protein in the diet.
And again, there's more data to be generated here, but at least where we're standing now, do you see certain types of patients who might be good candidates for its use as monotherapy as opposed to its use as an adjunctive treatment?
I think there are patients where it would probably use as monotherapy, patients who are not Kuvan responders and who are not interested in pegvaliase at this time, and we can see how much it will allow them to liberalize their diets.
Okay, and we'll find out soon about the design of their phase 3 study. But given what we know about PTC's Affinity phase 3, is there anything you would recommend be different about the design of Synlogic's phase 3 study?
Not really. You're going to have a study arm and a placebo arm in order to show the efficacy. And so that's just, unfortunately, part of how we have to do these trials to be able to prove that it's efficacious. So there will have to be a placebo arm and a drug trial arm.
And the part 1 and part 2 aspects of Affinity, you think that's a good way to zero in on patients for the randomized part of the study in part 2?
I think it is. And I think it's also a time limited, where you're going to have to be on the placebo versus the real drug. And I think that's important to the patients. In good conscience, we want our patients to help with studies and learn new and be able to have new options. But at the same time, we don't want to penalize them because they're in the study. So a short time period, as is indicated in the other study, I think is the way to go, where you're going to potentially have some of the patients on the placebo.
Okay, great. Well, let's talk about gene therapy and gene editing. As I said, a number of candidates targeting PKU being developed by companies like Homology, BioMarin. And maybe to start, given the proposition that these could be potentially one and done therapeutic approaches, what kind of patients might benefit from this type of therapy? Let me start with Dr. Burton here.
Well, I think the patients who would be most likely to benefit from a gene therapy would be our older patients, adolescents and adults who have gotten into that situation where they have poor metabolic control, and now they have the option of going to pegvaliase, or they could choose gene therapy. We don't think it's truly going to be one and done. We certainly, with gene delivery, AAV mediated gene delivery, we know there's liver cell turnover even in the adults. So we see it as a long-term therapeutic option potentially, but maybe not forever, probably not forever. So those would be the target patients, I think. But I personally feel there's been a lot of cooling of enthusiasm for gene therapy in recent years in PKU, both because of the clinical holds that have gone on, but also slowing progress, but also with other emerging therapies, and also with the short-term risks that have emerged from other gene therapy trials. I think the risk-benefit ratio doesn't look quite the same for PKU as it does for some of our more lethal diseases, or ones where the patient's frequently hospitalized and so forth. So I also feel that the bar for efficacy is very high for a gene therapy, because there are risks and because it's not a walk in the park to get it. There's immunosuppression, high dose steroids many times, which have their own side effects. The patient has to weigh all of that, and it needs to be as efficacious as Palynziq in the end. So we need to be able to get to the patient to a well-controlled blood Phe level with an unrestricted diet. And we saw from the data that Homology showed with their gene delivery that it wasn't efficacious enough. Now they have the gene editing trial, and there's been no data from that. That may look different, and we haven't seen any data from BioMarin. Their AAV, they have a different vector, so theirs could be certainly more efficacious. They're still on clinical hold, so we'll have to see. But again, that I guess would be my overall assessment of it. I don't know if Hope disagrees. Maybe you want to weigh in on this.
Totally agree with Barbara's comments. I think that it's not appropriate for us to call it one and done, because we do not know how long the durability is going to be. It could be 5 years, it could be 10 years. But my hope is that if someone does receive gene therapy and they have good phenylalanine levels for 5 or 10 years, that by then the medical and scientific community will continue to move forward and will have another option for them. Because once they have received that gene therapy with that particular vector, it's no longer an option for them. So I think that's one important point that we need to think about. And as Barbara was discussing, it is no walk in the park to get someone to gene therapy. And we are worried about off-target effects and other side effects that could be potentially very scary and very life-threatening. When we have diseases where the patient is going to have premature death because of the disease, it's a little different to think about gene therapy than it is in something like PKU, where we can treat it and we have a lot of options, and quality of life might not be perfect, but you are going to be alive, and quality of life continues to improve. So I agree with those statements. I mean, for PKU in particular, gene therapy is probably not as attractive as it is for some of the other diseases we take care of.
Okay. For either of you, are there any other early stage clinical programs targeting PKU that you think could be promising? And maybe I'll start with you, Dr. Northrup.
I don't really know of any others at this time. Barbara may have more insight about that than I do.
I personally really like the Janana approach that is preclinical currently, but they're headed into the clinic this year, already in startup efforts. And that approach is very attractive because, again, it's oral, and they have an inhibitor the transporter at the renal tubular level. So the mechanism of action would be to let the patient basically just pee out phenylalanine. It's analogous to the drugs for diabetes that we have that inhibit the glucose transporter. And the nice thing about Janana is not only it would be oral and they're projecting once a day, but also we have a biologic model for what we might anticipate in that there are patients with genetic mutations in that transporter. And those patients appear to have a completely benign phenotype. So they don't seem to suffer any adverse consequences as a result. Now, they're not PKU patients, so still, safety is going to have to be carefully assessed. But I'm fairly optimistic that if their approach is efficacious, it will likely be safe. And the other nice thing about it is, like Hope had said with the Synlogic, where you could potentially use it in any PKU patient, that would also be true here. And you could also combine it with other therapeutic modalities. So we might be able to take several of these oral drugs together. And although any one might not be fully efficacious enough to get the patient to a normal diet, several of them together could be. So I like that one for sure.
Great. And maybe we'll wrap this up with a couple of questions about market dynamics. But given that we have multiple new therapies under development, do you believe the market is large enough or diverse enough to support multiple new therapies? So let me start with you, Barbara.
Oh, I definitely do. I mean, we have, PEG Valiase is a great drug, but we've heard it's not for everyone. It clearly is not for everyone. Some patients don't want it because of what's involved, and some can't tolerate it. And we know that Kuvan is not for everyone. PTC is not going to be for everyone. So I think we have room for these alternate therapies that, could impact any patient potentially, but where they may just be adjunctive. Of course, we have to see how it plays out. I mean, maybe one of these will, maybe Janana will be so efficacious that it could be a standalone therapy. That would be wonderful. But, it's likely that we're going to have combinations of therapy, and our treatment of patients with PKU is going to be individualized for the individual patient. So I do feel like there's room for all of the ones we've discussed.
And Dr. Northrup, anything to add there?
I definitely agree. Our 21st century mantra is personalized medicine. And I think PKU is the poster child for that, because not every drug is for every person. Not every drug works appropriately. And it may even be that people over the course of their lifetime use different therapeutic options when they're babies versus young children and as they get older. So I think there's room, and we need to do better than we've done in the previous 50 years of PKU treatment, that we thought we were doing such a great job and we really weren't. So I think there's room for all right now. We're just going to have to see how it all plays out. I agree with Barbara completely.
And let me ask you how you think pricing factors in here. We got current therapies that represent a mix of dietary management that may be individually low cost, but certainly add up. We've got generics, and we got a relatively expensive branded drug. So in your opinion, how much of a factor does or will pricing play in market adoption, market penetration? I'll start with you, Hope.
I think marketing and price is huge. And as time goes on, we see the insurance companies kind of catching up with us and figuring out what we're doing, sadly. So I've recently seen sort of a ratcheting down of the companies with me in my prescription of Palynziq. They're requiring more and very specific verbiage in the notes about how we're using it and the efficacy and how everything's going with it. And I think over time, they're going to continue to do that. Although I will hasten to say that I feel like genetic therapies are becoming so much more ubiquitous in the market that acceptance has been gained. A lot of acceptance has been gained. And as we continue to develop more therapies for more genetic diseases that are very boutique and very niche, that's going to continue, and the companies are going to have to begin to accept it. We hear stories about all the different therapies and how wonderful they are for the patients. And what the companies then end up having to look at is long-term and lifetime costs versus, for example, for gene therapy, long-term costs that you would have incurred otherwise if you hadn't used that very expensive therapy up front. And then we look at other things. I think we're going to be able to look at other factors, like I was talking about how in PKU patients with our dietary therapies we had in the past, we wound up with all these long-term morbidities in patients. And that's going to have to all be taken into account when we look at costs and kind of factor it out. Also, as time goes on with new modalities, price comes down. Generics are created, like with Kuvan that Barbara was mentioning. So I think, again, it's a shifting marketplace and we have to watch what happens. But I see more acceptance for genetic therapies. And as our technology gets better, so those therapies are going to be cheaper.
And Dr. Burton, anything else to add?
Not really. I think, what Hope described could happen over time. Up till now, I will say that I've had very few, if any, PKU patients for whom we have not been able to get the therapy that we wanted to prescribe. The only exception would be some of the dietary products in adults that are really poorly covered by payers. But as far as the pharmacologic therapies, generally we get them and the patients generally have very little out-of-pocket cost because of the companies, providing copay assistance and so forth. So that hasn't been a major issue in how we utilize them. And the two drugs we have are very different, obviously. So it isn't one versus the other. Now, as we get more therapeutics, and we talked about it with the PTC, where really it's similar but better than Kuvan, right? We could start getting into some of this, issue of whether we have to fail one to get another. And we may wind up with some difficulty if we start wanting to use combination therapies of very expensive products, and that combination has not been specifically tested in clinical trials. I could see that occurring. But up to now, I think we've been blessed with the ability to largely treat patients in the way we felt was medically best for them.
Okay. Well, a final question. I'm going to ask you both to look forward. If we have this conversation 5 years from now, how will things change in terms of how you describe how you're managing patients with PKU? Let me start with you, Barbara.
I think the diet is going to assume a shrinking role over time, so that hopefully one day we won't even mention the possibility of dietary therapy. We won't need to, because we'll have other interventions that we can use right from the time of birth. So I think over time we'll see less and less reliance on dietary therapy as these newer pharmacologic options become available. Hopefully within 5 years. A couple of them will come to market and will, have options that we haven't had before. So I think that's a major change I see.
And Hope, give us some hope here.
Oh, it's going to be wonderful. We'll have so many options, and babies born now are going to get such better care than we were able to provide 35 years ago. And it's going to be so much better for them. It's so less frustrating for us to be able to give them a better outlook, better quality of life. Very exciting.
Well, great. Well, we've gone about an hour, so I think we'll wrap it up. I want to thank both of you so much for joining us today, as well as our audience participations. Our participants, I'm sorry. We will have a replay available later today or tomorrow. So again, thank you very much, and we'll wrap it up here.
All right. Thank you, and have a good day, everyone.
Thanks so much.